last session, before moving further, I would like to express my gratitude to Magical Formula and team for organizing such a wonderful conference. Thank you and have a great day. Now I would like to call on dais Dr. Rozil Gandhi for delivering the topic Prostatic Artery Embolization, followed by vote of thanks.
Good afternoon, everybody. So I'm standing before lunch. Last topic, as I mentioned, intervention radiologist, we have something for every organ, and for prostate also we do the same. We embolize the prostatic arteries. So use of prostate, it is a vestigial organ. And what is benign prostatic hyperplasia? So above 50 years, every male has a mild or minimal or of some degree of prostatomegaly. So benign prostatic hyperplasia is a non-cancerous growth of transitional zone of prostate which surrounds the prostatic urethra. So when it becomes enlarged, it compresses the urethra and causes various symptoms. The various symptoms which it causes, it is called LUTS, lower urinary tract symptoms, and bladder outlet obstruction. It significantly degrades the quality of life in an old age male. It is divided into two parts. The symptoms are divided into two parts: irritative and obstructive. Management, the most common management is alpha blockers, medical management. Second is TURP, and we have placed prostatic artery embolization in between. It is a minimally invasive therapy. So how to evaluate a patient with prostatic enlargement? Symptom evaluation by objectively is by IPSS score, that is International Prostatic Symptom Score. Per rectal examination to whether the prostate is hard or soft. If the prostate is hard, basically we have to rule out malignancy. Serum prostate specific antigen levels, PSA levels, to look for malignancy, and routine blood investigations. MRI prostate or a CT angiogram depending on the previous examination, if we are suspecting anything abnormal. This is IPSS score. It is based on the symptoms of patient, whether the patient has incomplete emptying, how is the frequency levels of in the night, how is the frequency of passing urine, whether the urine passing is intermittent, how is the urgency level, how is the stream, and how much patient has to strain. So based on this multiple symptoms, we are giving points to all symptoms, and IPSS score is calculated. 0 to 7 points, the score is mild symptoms, and above 8 to 19 it is moderate, and higher are severe. Prostatic artery embolization has emerged over a last period of 5 to 7 years as a truly minimally invasive treatment option for patients with lower urinary tract symptoms because of benign hyperplasia. It is not used for prostatic malignancies. So there are multiple evidence-based guidelines now and multiple papers and trials proving importance of prostatic artery embolization. Indications, it is BPH with refractory LUTS or intolerance to medical treatment. Contraindications or patient's refusal to surgery, indwelling Foley's catheter or urinary retention. It can also be done for hematuria with bleeding from the prostatic gland. I'll show two cases. 68-year-old male, history of hematuria since 4 days, no history of trauma, fever or any procedure. CT showed a small aneurysm in the prostatic artery in the prostate parenchyma. So this is the CT picture. It shows a small pseudoaneurysm in the prostate, which was picked up on angiographic image. So this is the inferior vesical artery and this is the prostatic branch. So this is the pseudoaneurysm which we have embolized. These are the embolization material in the prostatic artery. Procedure is done under local anesthesia. As I mentioned previously, it is a safe pinhole technique, minimal complications. CT is performed in the cath lab itself to identify the prostatic arteries and to protect the bladder base from getting necrosed because of the embolization particles. So CT in the cath lab is very important. Studying the anatomy and the branches of internal iliac artery and to select the right branch is also very important to select the right view. We go with a 4 French 5 French sheath, and 1.3 millimeter is the 4 French diameter. So this is a schematic diagram showing the bilateral prostatic artery, and we embolize it by injecting small particles. So this is what the particle looks like. Post procedure immobilization is for 6 hours, and patient can resume normal activities after few days from the next day. Again, another patient, left side prostatic artery. This is the prostatic blush. Similarly, left side prostatic artery, and this is post embolization. You cannot see the blush. So what happens is the prostate becomes necrosed, so it becomes inactive, and the pressure symptoms reduce, and there is 25 to 30% improvement in the IPSS score in first 3 months. This is right sided prostatic artery. Benefits: it is minimally invasive, lower risk of urinary incontinence, no sexual side effects like retrograde ejaculation that is seen in TURP, less pain and discomfort during and after the procedure. Criteria for symptomatic improvement are defined as IPSS score of less than 18 with a decrease of at least 25%, and quality of life score less than or equal to 3 and at least 1 point decrease compared to the score at baseline. So IPSS score helps in evaluating the embolization procedure. Clinical failure if the score has become more or there is persistence of severe symptoms. Embolization shows a success rate of 80% at 6 months and 75% at 12 months. Recurrence rate are higher than the surgery, but it is minimally invasive. It can be done once again if required, and it is a procedure with minimal risk. Side effects: non-target embolization. If the embolization is done to other arteries, then there can be side effects, and other side effects of angiography like femoral artery bleed. So all side effects are less than 3%. So this is how a prostate looks before, how it looks after TURP. The prostatic urethra size increases, and this is how the prostate looks after embolization. The size of the prostate has reduced, the urethra is normal. Follow up with the clinical findings and imaging findings. IPSS score is evaluated, and MRI can be done if required. Thank you. At the outset, and I would like to thank everyone. First of all, Dr. 𝘂𝙘𝙘𝙪𝙡𝙖𝙧 and Mr. Nilesh Soni of the Health One Hospital for providing the platform. Second, Rushi and Deepak Bhai for very good software and everything. Speakers: Bhavesh sir, Jitendra sir, Drushi, Ankur Bhai, Gaurav, and audience who have seen and who are going to see. Thank you, everybody.